Good afternoon, everybody. I hope you're all well, and welcome to our ICB briefing session. Delighted that you can join us this afternoon. I'll do some introductions first of all. I'm Steve Jamieson, the Chief Executive here at the Royal College of Speech and Language Therapists. And with me today is my colleague, Derek Munn. Derek is the Director of Policy and Public Affairs here at RCSLT. So we're delighted to be here just to talk and give a bit of an update and a briefing really on ICBs. I just wanted to share with you sort of the purpose of today's session. And some of you will know that I spend quite a bit of time just going around meeting members across the 4 nations of the country, and to hear from our members about what are the issues for them, what are the issues that they feel they need to know more about. And one of the things that kept coming up, certainly for our members in England, is about the role of ICBs and what does that really mean for speech and language therapists. So Derek and I thought it'd be a really good idea to have a session, i.e. this afternoon, really just focusing on ICBs and looking at the role and the structure of ICBs, just to bring up the knowledge of our members, those people who are trying to think about where their role as speech and language therapists fits into the future direction of ICBs and ICSs. So today we're going to give you an update on that. We're going to give a little bit of history as to where ICB sort of originated and the impact that's had so far. We'll give a brief update on the key elements and how ICBs actually work and function. I think that's key for you as our members to be able to really understand some of the issues affecting us in the world of working in the world of ICBs. Obviously, quite a bit of information that Derek and I will be sharing with you today is what we know today. But as you all know, there are many changes happening within the world of the NHS. So what we're saying today may be very different in a month or 2 months' time. So you'll have to bear with us. And obviously, we will continue to update you as and when those changes happen. We will talk to you about the changes in the commissioning models and about the model blueprint, which is something which is really important for us around the future direction of this. And then there'll be an opportunity for you to ask Derek and I any questions that you may have, and hopefully we'll be able to answer those. Just a couple of housekeeping issues. One is that if you are knocked off for any reason and come out of the call, then please just rejoin on the call on the link that you did originally. And the session is being recorded and it will be put onto the RCSLT website over the next day or so. And if you do have any IT queries, such as myself right now, please can you put those into the chat, and one of the team will be able to respond to those. So I hope that is helpful, and I hope that out of the next sort of 45-50 minutes, you will get some information which will be helpful to you as a speech and language therapist in your day-to-day roles. I'm just going to see if my slides are working now. Okay, so could we possibly have the next slide? I've got my helper here who's going to be, Yasina is going to help you with moving the slides forward. So not too sure what's happening with my slides. So first, I can't see the slides, Justina, but
that's moved on, Steve, we're fine.
Okay, that's fine. I can't see them. So can I just see what slide you're on? Okay, Derek, can I hand over to you just to talk us through the story so far?
Yes, thank you. And I'll try and give a 10-second warning for each slide moving forward so we can catch up. Otherwise, those who've heard me speak will know I'm well capable of filling in. Thanks all. As Steve said, for those who've not met me, I'm Derek. I'm Director of Policy and Public Affairs. Look, I'm acutely aware that some people on this call are senior colleagues who live and breathe ICBs and ICSs. So please feel free to correct me if I get things wrong, and also to add your own perspectives based on your own leadership and experience. Others I know will be colleagues who are here to learn, and we're going to take it from the top. Hopefully that will be of use to everyone. I worked for many years in Scotland, And in Scotland, there hasn't been a governance change in the NHS for the best part of 50 years, apart from some small geographic boundary changes. You simply have a health board. If you live in Glasgow, there's the health board. And the health board employs, commissions, provides, funds. There is only one NHS entity for each geographic part of Scotland. So you can imagine my confusion in moving back down to England and working for the Royal College, when one of the first things I had to deal with was what became the 2012 Health and Care Act. Because the sheer number of competing and overlapping organisations in the NHS in England, was and continues to be a source of confusion and in some cases concern. And the 2012 Andrew Lansley reforms from the then Conservative Lib Dem coalition were what broadly led to the context in which ICBs appeared, I would say. Amidst the alphabet soup, the two we would pull out would be CCGs, clinical commissioning groups, which were the groups of GP practices who were meant to come together to commission services in their area, and a quango, a devolved body, a non-departmental body, called the NHS Commissioning Board. And the NHS Commissioning Board was meant to do the central stuff, but it was made apparent from the beginning that the NHS Commissioning Board would be known as NHS England. Okay, so its job was just commissioning, but it was to be called NHS England. And then you had trusts and foundation trusts and Health Watch and all the other paraphernalia of the 2012 Act. By about 2016, it was clear that this governance complexity was not working effectively. And there was an invitation for NHS bodies in defined areas to come together in what were then called Sustainability and Transformation Partnerships, STPs, which in due course became integrated care systems, which then existed in shadow form for a period of time until they were eventually put into legislation. Now, today is going to be odd because the first slides I'm going to give you are going to be our best take on where things are at with ICBs as of now, but I'm then going to go on to talk about announcements that have been made this year and the model blueprint mentioned on the opening slide. So I'm about to talk you through the status quo, which may be all about to change. And we need to know where we are before we know where we might be going to. So this is where I begin my filling in. Well, I hope that a new slide will appear any moment now. And on that new slide will be, oh, there we go. So integrated systems, what are they as of the 22nd of July, 2025? They may not be this sooner rather than later. Partnerships of organisations work collectively to plan and deliver joined up health and care services in their area. So from July 2022, at one point there were 44, we ended up with 42. 42 integrated care systems established across England on a statutory basis from 2022. So we'll do this in diagrammatic form in a moment, but each ICS contains an ICP and an ICB. It will become as clear as it's possible to be. What are they tasked with? Improving healthcare outcomes, tackling inequalities, enhancing productivity and value for money, and supporting broader social and economic development, all while delivering joined up health and care services in their area. So nothing if not an ambitious brief. Okay. So there's the potential for endless confusion between an integrated care board, an integrated care partnership, and an integrated care system. The integrated care system is the overarching thing for your area. Within that, you've got the ICP, which is meant to be a partnership between the NHS, local authorities, and others can be invited to that table. And they are looking at wider health and care population needs. They're doing so alongside architecture that comes from the 2012 Act called the Health and Wellbeing Board, which is a creature of the local authority. So you already had, as we have it now, the ICP with some kind of overlap with the HWB and the Joint Strategic Needs Assessment and some of that other 2012 alphabet soup. So things are still not as efficient as they might be. But what you have got now is the ICB, responsible for planning and commissioning. And this replaces what the CCGs were doing. In other words, it's no longer theoretically the partnerships of GP practices. It's now the NHS providers in an area, essentially, deciding around commissioning. So what this does, and it was done by the previous Conservative government, is bring an end to the 30-year purchaser-provider split. You've still got commissioner and provider, but now in some cases you've got the same bodies on both sides of the table. Now, we had an immediate concern that those ICBs would be subject to the kind of centrifugal pull of big acute hospitals. And there would be a tendency for the commissioning in a given area to get focused upon hospital provision, and in particular acute hospital provision, at the expense of community. And to some extent, we would say that has happened in practice, but we'll come to that. Okay, so continuing with the system as it's supposed to be now, we move on to how AHP, allied health professions, are meant to be represented. And this has been very variable across the country. I know Murray and others on the call will have strong local experience of this. But in theory, each of the 42 has an AHP council of chief AHPs from providers, an AHP faculty whose job is to look at workforce supply, although that was already being dismantled to some extent prior to the current wave of changes, and an AHP lead. Some systems also have a chief AHP, but not all of the 42. Now, this is the slide most of all that I would say was sometimes honoured more in the breach of the observance and is most likely to be changed as we move into the new architecture. But there was at least some recognition of the role of AHPs in the system as set up from 2022. Okay. Just as you think you've caught up with the last, moving on, just as you think we've caught up with the latest, oh no, before we move on. So before we move on to what's changing now, here's what we've been arguing for since ICSs came along. From the STP days in 2016, through the shadow days, into the statutory days. First of all, we had a success in the 2022 Act in getting what's called a primary legislative requirement. In other words, written into the Act of Parliament that ICSs need to work on children and young people. And that enabled us to get guidance and to say, we can hold ICSs to account for how they are or are not delivering on their legislative responsibility to do things better for children and young people. But again, question to what extent that's been effective. We tried during the passage of the legislation, but didn't succeed in getting rehab written into the law in the same way. And because it's not in the primary legislation, there isn't guidance, statutory guidance on it. And we've had to fall back on, trying to promote the importance of rehab and community being part of what ICSs do and how they're assessed. We've talked all along about the need for ICSs and ICBs to plan and commission, not just for NHS services in that area, but for the whole health and care economy across their area, which would include, for our purposes, independent providers of SLT. But it also, within that, includes the crucial issue for SEND and other aspects of children's services of joint commissioning and preferably pooled budgets between NHS providers and local authorities, which we've continued to promote at every level through the new system. Then, as part of the role about commissioning, we were able to say, okay, given that an integrated care system is bigger than an individual trust, and it has a larger population footprint, that means that there are some conditions for which the incidence and prevalence means you can commission an appropriate pathway, including specialism, better at the level of the ICS than at the level of the individual trust. Yeah? And examples for us of what we would call low incidence, high need conditions would be hearing loss, selective mutism, complex stammer. And we've pointed to, for example, the Cheshire and Merseyside hearing pathway, as a model of how you can come together across an ICS footprint to do that kind of work. There's also those aspects of very rare or complex or expensive service, which ever since 2012 have been centrally commissioned by NHS England. And since 2022, a process has begun of delegating them down, first of all, to regional clusters of ICSs and ICBs. And for us, this would include things like cleft, it includes things like gender identity services. Okay, so that's what we've been lobbying for in the current system. That brings us on to the changes proposed this year. The screen grab on the right, I know it looks like it's been done in clip art. That is genuinely what the cover of the document looks like. It's no more exciting than the Model Integrated Care Board Blueprint version 1.0, which is the document to which we are all working right now. Now, on the same day that Wes Streeting, the Secretary of State for Health, announced that he was going to overturn the 2012. Remember what I said about the 2012 Act and the NHS Commissioning Board, commonly known as NHS England. So that body was set up by the 2012 Act. And at the time, many people, particularly on the left, said it was a democratic outrage that you were taking responsibility away from the Secretary of State, the NHS, and giving it to an arm's length body. What Wes Streeting has now decided is he's going to get rid of the NHS Commissioning Board, commonly known as NHSE, and merge it back into the Department of Health and Social Care. And we have many views and opinions on that. On the same day, an announcement was made about there being the need to reduce management costs in integrated care boards by 50%. Yeah, a massive in-year cut that ICBs are now being expected to deliver. And that's the context for the model blueprint, which we would say contains more questions than answers. Now, it flows from the Darcy review. When Labour came in last summer, they set up the Darcy review. Steve was part of the steering group for that. And the Darcy review, amongst other things, and it's however many 170 pages or whatever, said that ICBs should be strategic commissioners. They should have a narrower focus in what they did. And if you look at this blueprint, and there's a link there, we probably put the link in the chat actually, would be a good idea, colleagues, then a lot of it, after some narrative about the importance of strategic commissioning and population health, a lot of the document is a table listing things that ICBs are going to keep and responsibilities that ICBs are going to give away. Yeah, and the discussion right now in ICBs is how to make that happen. So we've been through, I think I can probably recite the Model Integrated Care Blueprint now. And we as the Royal College of Speech and Language Therapists have a number of things we like, things we don't like, and things we are seeking further information in terms of what is proposed. Moving on. So, things we welcome in the model blueprint. The focus on population health and prevention. Yes. The rhetoric around shifting the focus from institutions to population outcomes. Absolutely. A focus on reducing health inequalities and inclusion. Absolutely. User involvement and co-design. Well, yes, but we all know that that's a lot of these things are easy terms to use and they're harder to do in practice. Developing and agreeing best practice pathways. This is potentially quite exciting. If ICBs are being given funding to actively go, here's a way we can deliver this pathway better and resource it, that's a good thing. And as mentioned on the previous page around hearing loss and selective mutism and stammering and cluttering, we've got ideas we can give them. Future investment decisions guided not just by precedent. This is really important. We know that there is a tendency, it can happen in speech and language therapy and other areas too, to still be delivering legacy arrangements that have been going on since the 1990s or the 1980s. And actually to say, you shouldn't just keep funding what you've always funded, you should look at doing things differently and better. Great. And co-design with local government. So all of this, which is in the rhetoric part of the model blueprint, is stuff that we welcome. Okay. Areas I've tried desperately to get this on one slide. This breaks my rule about how many words you put on a slide. Hey, we've got a lot of concerns. Workforce reduction. Look, at the end of the day, if you're asking an organisation in year to make a 50% cut in its management costs, that's going to affect efficiency. It's going to affect morale. It's going to cause disruption. The expectation is that ICBs are going to merge with each other. That each ICB will merge, 2 or 3 ICBs will merge down into a smaller number. And those discussions are going on right now. And of course, local authorities, which have political control, are involved in those conversations. And we've had at least one example already where a county council, now under the control of Reform, has seen Reform exercising their veto over who they're going to merge with and who not. Yeah, based on rurality, as far as we can, assumption, shall we say, about the population makeup, which might be the kindest way to put it. Okay. So the resource reductions and the pace of them, but also the transfer. I mentioned that the blueprint is full of tables about here's what the ICB is going to keep, mostly what I put on the previous page about population health and health inequality and so on. And here are things which are going to go either down to individual NHS providers or up to regional and national level, or a combination of the two, and it's not always clear. Probably the biggest one for us is SEND. Yeah. So I mentioned, what we've been arguing around joint commissioning and pooled budgets and so on. SEND is in the table. Now, I assume it means SEND is going back down to individual providers rather than up to national. But of course, this has a huge crossover with the current conversation about SEND reform, and in particular, the future of education, health and care plans. If commissioning for SEND is explicitly taken out of the ICB remit and goes back down to providers, and alongside that safeguard. Okay, but there's a bunch of other stuff which ICBs are no longer going to do. All the sustainability and greener NHS stuff, no longer ICBs. Sustainability goes back to individual trusts. Okay, digital, some of that goes up, but some of it goes down. Infection control, no longer done at the level of the, and this is all part of what's deemed to be the focus on strategic commissioning, leaving providers to do things like environmental sustainability and infection control. Now, there's a question there about what is strategic and what is not. The decentralization of workforce planning. So education and training is proposed to move away from ICBs. Now, again, this raises a question, a risk at least, around fragmentation, across an area. And sustainability with the amount of resource per head. So all of these are things which could be a concern unless this is got right. Okay, there's other areas too where we are seeking to have further discussion with individual ICBs and with the system at national level. So moving on. Reassurance needed, I've put here. So remember I talked about that stuff which was, since 2012, has been specialist commissioned by NHS England. All of that national commissioning is going to be reviewed, presumably with a view to it being devolved down. Now, those areas, I mentioned cleft and gender identity, but there are others. There's the most complex trauma and a range of other things. Currently have a national blueprint. Even where they're delivered at regional level, they have a national specification. We're involved at the moment, for example, in a campaign to get primary progressive aphasia added into those national specifications. Now, with the assumption that they all get devolved down, we need to know how that's going to work in practice. The blueprint says direct resources where they will have the greatest impact. Yes, of course, but that cannot just be a numbers game. As we often say, it doesn't matter how rare a condition is, if you've got that rare condition, it's the center of your life. And greatest impact can't just be which conditions have the most numbers. Forecasting and modelling demand and pressures, yes, of course, ICBs should be doing it. We would always say, and we would think here in the context of SLT, around areas such as justice and dementia and mental health, that you need to forecast and model for unmet need, not just the demand for services that you already provide. Okay. Outcome-based contracts, it says. Yes, of course, but that needs to genuinely be clinical outcomes, not outputs or activity in disguise. And then, Steve has co-written with the other AHP CEOs a letter around clinical leadership from AHPs being represented in the new structures. And through the Community Rehabilitation Alliance that we are part of, we're continuing that campaign to have a dedicated rehab lead in each ICB. Okay. I hope you're keeping up. You can revise it afterwards. There's more in the blueprint. Encouraging new providers. Yeah, so this is non-NHS providers, and they specifically mention frailty. Okay. Workforce planning going to regions and nations. So you've got workforce going up to the nation and region and down to the provider, but no longer being done in the middle. And responsibility for data being transferred up to national level. Okay, so all of these things are going to need to be worked through. Okay. All of this comes in the context of the 10-year plan. It's got to be seen alongside the 3 shifts, and we're working really hard on how we articulate. Here's what speech and language therapy can do with the shift from sickness to prevention. Here's how we can be part of the shift from hospital to community. Here's how we can be part of the shift from analog to digital, not least given the reliance in the 10-year plan on the NHS app and the needing to ensure the communication accessibility of the NHS app. Here's how speech and language therapy can be part of making the NHS an economic growth driver by helping people to stay in work for longer, get back into work. And then the proposed neighbourhood health services, which are going to be critical and which are starting in pilot form this autumn. Here's how speech and language therapy can be part of your neighbourhood health service to support the 3 aims above. We've also got, following later this year, the NHS England Workforce Plan, which follows on from the 10-year. So everything we're doing around the changes to ICBs need to be set in the context of the 10-year plan. There you go. That's the end of my whistle-stop tour. I hope for those on the call who know more than me, I've got that broadly accurate. Happy to take both questions, but also your views on what we need to do and your views on things that the Royal College might usefully provide for you. Thank you very much for your time.
Derek, thank you very much indeed. I hope everybody is 100% clear now on ICBs. There will be an exam at the end of this, so it is very confusing, and Derek has done a brilliant job at being able to navigate us through what is really a complete puzzle for all of us. So we're all struggling, I know, to get our heads around this. And as Derek said, and I think I said right at the beginning, there is all of this will change. And so what we're saying today may be very different in a month's time. So bear with us. The Royal College will continue to update you on the changes that are happening and how that will affect us. But I guess I just wanted to finish off by thinking about, so what should you as a speech and language therapist do next? And I think the first thing is about keeping discussions open about the future of your ICB and how it's merging, where it's going, what's the direction of travel. I think that's really important to find out from your line managers, from the people who are leading the ICBs, just what's happening and how that's going to impact on your day-to-day work. Be really involved in the SLT and allied health professionals conversations, and how can you influence that? I think what's really important here is that speech and language therapists have a real opportunity to influence the direction of travel that we're moving in. And as Derek rightly said, the 10-year plan, we do need to get much more actively involved in that. So with RCSLT help, but also with you being much more involved in the conversations, we will have a clear picture and we will be much more actively involved in the work moving forward. It's also thinking about what services and pathways do you as a speech and language therapy need to ensure that they're helping through those changes. So how can you help to steer the service through some of those many changes? Only you know your area of work, you know the community, the neighborhoods, you know what's happening in those areas, and only you can really help to steer the direction of travel with that. So one of my pleas is, as speech and language service, please do speak up, because your voice is so important in getting the services right for our service users and our patients, and look at what new opportunities are presented and how these will affect you and how you can actually affect them as well. So, and the last thing to say is that as a team here at Royal College of Speech and Language Therapists, we are here to help you. We're here to help guide you. If there are any questions at all in relation to ICBs, the future, how you as a speech and language therapist can be much more actively involved in that, then please just drop us an email, lift the phone, and chat to us about how we can support you in your day-to-day work. It's really important that we do that. I also just want to say the slide deck that you've just seen will be available on the, it'll be shared on the website, RCSLT website fairly soon. So you'll be able to see all of those slides again, which is really great. So now I've got some time for questions. I won't be able to see all the hands for questions, but if you have a question, would it be possible for you just to unmute and say your name, say where you're from, and ask your question, or just a point of interest or a comment you'd like to make? Anybody want to start? Murray, good afternoon.
Hello there. I'm Murray Sivright. I am currently Deputy Director for Allied Health Professions down in Sussex in University Hospital Sussex Foundation Trust. Our local ICB, like many others, has been decimated with the culling that they've been going through this year, and we have lost our chief AHP. We haven't had an AHP faculty for coming on a year and a half now, maybe longer. And the AHP Council was operating, but in a different guise. And there's now rumour, I may prefix this with only rumour, that the ICB from Sussex may merge with Surrey. So this is what we're hearing on the ground at the minute. And the thing that I'm curious about, if that were to go ahead, and we don't know the answer to that, but with the Sussex is also exploring developing the Mayor of Sussex role, similar to Andy Burnham in Manchester. And I guess what I'm unclear about is how these mayors interface with the ICBs, because obviously part of the mayor role for a county is to oversee the health and social care and police and roads and all the various bits. And I'm just, at the minute, I'm not sure, because it's new and obviously they haven't appointed anybody yet, but how that works in practice. And I don't know, Derek, if you've got a view on this from what's been happening in Manchester specifically. That's the one that I can think of, Andy Burnham being the mayor up there.
Thanks, Murray. In terms of what's proposed going forward, I don't think they know either, to be honest. And obviously, there's no suggestion that there'll be metropolitan mayors, as they're called, in every part of England. In terms of the experience of Greater Manchester, it's not been unhelpful. And actually, Steve has met with Andy Burnham, and he has expressed a strong support, particularly in the area of children's language. And actually, Greater Manchester is a model that we point to. Now, obviously, that's a big population for because it's 2.5 million. And there is a single pathway led by Michelle Morris across the whole of Greater Manchester relating to children's speech and language, which is one of the models of good practice to which we point. But clearly, if there were to be a mayor for the whole of Sussex and Surrey, they could be from a very different political perspective and would carry those values into their expectations.
Thanks, Derek. And I think just to echo, I've been doing some work with Andy up in Manchester, and actually he is an amazing role model really for the work that he does in Manchester. And I think if we can do anything, Murray, if they are thinking of going down the route of a mayor for Sussex and Surrey, then I think we need to make sure that they're pointed in the direction of Andy's model, just to see. So as Derek rightly says, he's done a lot of work. He's held a lot of meetings up there in relation to speech and language therapy and the impact, especially on children's services. Yeah, he's someone that is very supportive of this profession as well. And I think what we can do, once we find out a bit more, Murray, if you did find anything out, and give us the heads up I think we'd be able to sort of point you in the direction of Andy just to see what else we could learn from that.
Thank you.
I can't see all hands, but if there are any other comments or questions, please just speak out.
Can I just ask you a little bit about workforce planning?
You can, Helen, yeah.
I'm not obviously involved in that, apart from at like I was going to say the bottom end. It might be the top end, I don't know. But we used to have this really fab system in history. We had this really great system where services were asked about their staffing needs, and this was all collated and it was passed on to universities, and we tweaked the numbers of students that we trained so that we always had the right number of speech and language therapists coming out. And then that disappeared. And it seems that, well, it just seems to, from me working in a university, that actually doesn't seem coordinated in that way anymore. And it does seem a little bit chaotic. And I know you mentioned, Derek, about workforce planning and where that was going to sit. And I just, after a little bit of clarity, if you know, I appreciate you might not, and it might change next week, but it seems to be an incredibly important thing for services, as well as for us providing the next lot of speech and language therapists coming out.
Thank you. And Steve, I'm aware that you've been involved in some of these conversations as well. It's interesting, Helen. I mean, in Scotland, well, in Wales and Northern Ireland, we still have a system where the government, working with the local health boards, determines how many speech and language therapy students there will be. Yeah, which is what used to happen in England with most recently what we call the LEPBs, Local Education and Training Boards. Scotland's slightly different. It's done at university level. The last government in England got rid of that kind of commission numbers and basically said, if people want to study speech therapy, they can study speech therapy. Now, the result for us, of course, is that lots of people want to study speech therapy. So there have been new university courses that have come on stream in England. I hear what you say. It goes back to what I had on the previous slide about not only planning for services you currently provide, but for areas of unmet need. And we saw this in the past with some NHS workforce planning in England. Trust would be saying, for our current paediatric and stroke services, this is how many people we're going to need. Well, we were going from the Royal College, yes, but what about youth justice? What about dementia? What about mental health? What about our expanding role in eating, drinking, and swallowing? So I want a profession which meets the unmet need as well as the current demand. You are right that at the moment it's essentially a free market. The pipeline is however many universities want to put a course on and however many students want to do it. And that is tricky for those who are trying to go, well, how many placements do we need? And what are these people going to do when they graduate? I have seen no indication that there is any likelihood of returning to centrally commissioned numbers in England. The other aspect of this is apprenticeships, where the NHS workforce plan last summer talked about 5% of speech therapists coming through the apprenticeship route. Actually, we're already above 5%, and the demand continues to rise. So, but these will be conversations, Helen, for the workforce plan, which is now being developed in advance of being released before the end of the year.
Thank you. Yeah, it's a bit grim.
Yeah.
Hi.
Nicole.
Hi there.
Hi.
Nicole Prendeville. I'm a team lead for deaf service and speech and hearing service at Great Ormond Street. So I have a question about cleft, and I think a few of my colleagues from other units are here as well. So obviously there's been, well, there had been a derogation down to the ICBs, And now we're not entirely sure what's happening with funding for specialist services at a time when, you know, staffing is so stretched. Is there any clarity on, you know, even who to liaise with in terms of getting in touch with our partners in whoever will replace ICBs? Or how do we reach out to our new partners to kind of make this case? Because we never even, like, our service don't even know or didn't know who our ICB partner was. And it's all been a little bit.
Yeah. And look, let's be frank, if NHS England are going to talk to anyone, they're going to talk to Great Ormond Street. So you would think.
Wow.
No, you're right. So then the national specification is still there. Then we have the regional centres. And my understanding was that the devolution down was to the regional groupings of ICBs in the first instance, rather than all 42. So I think, so where we are now is that all specialist commissioning was in the process in 3 waves of going down to regional groupings of ICBs, and people were going, nothing new under the sun, regional health authorities, anybody who knows the older hands amongst you. All it says in the blueprint is all remaining specialist commissioning will be reviewed.
Right.
Okay. I can and will, based on your inquiry, Nicole, ask our contacts in NHSE. NHSE, of course, are in a 2-year process of being abolished and losing 50% of their
Quite, yeah.
Which is why I talk about us needing to have a very tight list of those services and pathways that need to be preserved through the transition. And as you've seen from my slides, I've got specialist commissioning with cleft. The first one I always use as an example, absolutely on the list. So do we have clarity? No. Are we concerned about it? Yes. Will I go and ask the question you've asked me? Yes.
Brilliant. Much appreciated.
And Nicole, just to follow on from Derek, I have a monthly meeting with Suzanne Rastrick, who's the Chief Allied Health Professional Officer for England. And that question actually is on my list to see. I'm seeing her next Monday, just to see what else information I can get from Suzanne. And obviously anything I get, we'll make sure we get out to our members.
That would be great. Thank you very much.
Sorry, I muted. Suzanne, good afternoon.
Hi there, I'm Suzanne Martin. I just wanted to ask a quick question on the back of what Nicole had raised. So I'm in the position where I work for a specialised commission service half of the week, and then I work for an NHS trust for the rest of the week. So split my time kind of, down the middle. The specialised service that I work for is the AAC specialised services, and that is another one that I suppose I wanted to flag on the list of we are kind of awaiting news as to what might happen in terms of how we may be hosted by the ICB clusters. But I suppose it made me think about what you were speaking to earlier around the awareness of some unmet need issues, and I think AAC is a really good example of that. So obviously the specialised services are commissioned at the moment, but we see huge kind of gaps at what would be considered like a non-specialist level that should be being served in kind of local trust or ICB levels, and so I suppose it was more around a statement around that, but also a question around I'm kind of concerned, I suppose, that whilst the shift from NHS England for the specialised services will happen, there'll be a big kind of gap still left with that unmet need at a local kind of non-specialist level. And I suppose it's kind of how we try and influence that, where there are just kind of either very few or no existing locally commissioned services. So it's almost kind of like how do we advocate for almost like a whole pathway journey without missing that kind of unmet need, and whose kind of radar is that on, I suppose?
Well, whose radar is it on aside from us? That is an interesting question. That's so fascinating, and many colleagues will know there's a particular challenge with AAC where the 10% most complex whatever was centrally commissioned by NHS England, and the other 90% was left over to local provision. And often I know charities such as Parkinson's end up fitting in the mix. I mean, not just England. Steve and I went to Belfast Children's Hospital a couple of years ago, where they're having to fundraise for iPads in children's acute and go, this is core tech. So it's what I said about what we've been trying to get ICSs to do in recent years is say, look, you've got the footprint to commission. I didn't mention AAC, but AAC would absolutely be one where, so I guess it's about saying, look, going forward, if you're strategically commissioning, there will still be things that are best commissioned at the population footprint of an ICS, making that case. The other thing, though, I think is an opportunity for us is the government shift on analog to digital, and in particular the magic words AI. And we as a profession, and I guess I'd look to the SENS and advise to support with this, getting our digital offer around AAC and say, look, here is a fundamental way that we are part of the digital shift and positioning AAC in that space.
Yeah, great point. Yeah, and I think sometimes it's easier to get some kind of traction around some of the tech-based solutions, but I think from a best practice and evidence-based kind of viewpoint, it's thinking about AAC as that broader kind of umbrella around strategy and paper-based resources and communication partner skills and everything that surrounds that piece of tech. And I think we've kind of historically learnt lessons around not just throwing equipment out there unsupported. And so it's finding ways of influencing that while still being able to really jump on the bandwagon of the digital.
Understood. And some of that, I guess, means you can cover it from absolutely the other end around the accessible information standard.
Yeah.
And actually, campaign going on right now, which RNID are leading around the accessible information standard becoming mandatory, and where AAC fits, the other end of AAC fits into that picture.
Yeah. Thank you.
Thanks, Suzanne. Any other comments, questions? Nope. So, first of all, I want to say a really big thank you to everybody who's joined us this afternoon. This has been recorded, so this will go onto the website as well. So you'll be able to listen back to it fairly soon, I guess. It'll be uploaded onto the website along with the slides from the presentation that we've given you today. As Derek and I said, and as others said, please just bear with us. Obviously, we will continue to update you as our members as and when things change. And we know right now things are changing more on a daily basis than a weekly or a monthly basis, but we'll try our best to keep you updated. But in the interim, if there are any specific questions or things you'd like some support with or ideas you have that can help others, then please just drop Derek and I an email and we'll be able to give you a call and pick that up with you and try and see how we can help each other, I guess, just navigate through some of these systems that are very confusing and very difficult for us to just really understand what's happening. But we'll do our best with all of this. So really appreciate your time and really good to see everybody. Thank you so much. And we'll be back in touch soon. Thank you. Have a good remainder of the afternoon.